Started? Okay. Okay, welcome back guys. Now in this class, let's discuss the remaining topics from the genetics. Okay, so last 2 days I couldn't take the class because of some health issue. Now today let's continue and let's complete the chapter genetics, so that we have completed the 3 chapters, that is the cell injury, inflammation as well as the genetics will be completed. Okay, so now let's begin without any further late. The topic which I am going to discuss now is non-Mendelian. Okay, non-Mendelian inheritance. So what are these disorders which follows non-Mendelian inheritance? Which diseases? Normally Mendel gave certain laws. This is how the diseases are going to be inherited. Okay, those are the normal: autosomal dominant, autosomal recessive, we have seen. Okay, so most of the diseases follow Mendel laws of inheritance, but there are certain special diseases which do not obey the Mendel's laws. What are they? Now very important for your exams. Number 1 is mitochondrial disorders. Okay, mitochondrial disorders. Next, trinucleotide. Repeat disorders. Next, concept of those disorders where there is genomic imprinting is involved. Imprinting and gonadal mosaicism. Gonadal mosaicism. So these are the 4 conditions. Okay, these are the 4 disorders which do not obey the Mendel's laws of inheritance. We'll discuss about them one by one. Okay, most important things we will discuss. Okay, now having said that, see, first mitochondrial disorders. First let's begin with the mitochondrial disorders. Okay, now let's begin mitochondrial disorders. Now first of all, here you need to understand, sir, what is the basis for this mitochondrial disorders? The basis for the mitochondrial disorders is, okay, the basis for the mitochondrial disorders is, see, you need to understand there are 2 sets of genes in our body. Okay, so the genes which are present in the nucleus, the chromosomes, and the genes which are present in the nucleus, majority of our genes are present in the nucleus. But do you know, even mitochondria in the cell, for example, let me put it this way. So if you see, this is the cell. Inside the cell there is a nucleus. Inside the nucleus there is DNA and the genes. But there is one more organelle in the cytoplasm which is the DNA. This is the DNA. Sorry, that's the mitochondria. Even mitochondria have its own genetic material. Even genes are present in the mitochondria. Okay. So if those genes can be undergoing mutation, there is a possibility that those genes can undergo mutation. They will lead to diseases. Possible. Now my question to you is, from where do you get this mitochondria? Okay, from where do you get this mitochondria? See, all the mitochondria which are present in your cells right now, okay, all the mitochondria, whatever are there in your cells, in your entire body, they are all derived from the mother. They are, you got all the mitochondria from the mother cell. Okay, see, from the father, you only got the genes, you only got the nucleus actually. Okay, let me put it this way. Now imagine, this is the ovum. Okay, this is the ovum, sir. Okay, now ovum with the nucleus. Here is the nucleus of the ovum. This is the ovum. Now here is the cytoplasm present. In the cytoplasm, mitochondria are also present. Mitochondria also present. Now sperm, dekho. Now imagine this is the sperm. Now when the sperm is fertilizing the ovum, okay, when the sperm is fertilizing the ovum, only the male pronucleus, the pronucleus is going to enter into the ovum. So father is not giving any mitochondria, father is not giving any cytoplasm. Okay, the cytoplasm, entire cytoplasm and entire mitochondria which are present in you right now, it came from the mother. So all the mitochondrial genes are also coming from the mother. Okay, this is the first basic point which I want you to know. Okay, first write mitochondrial genes. From where you got them? Derived from mother. Okay, purely maternal in origin, sir. Okay, father is not giving any mitochondria. Now, based on this, now I want you to write these two statements. Now, if a mother is affected, now if a mother is affected, mother is having some mitochondrial disorder. I will tell you what is the disorder later. Now, mother is having some mitochondrial disorder, sir. Now, if she is having four children, how many of these children will get this disease? All four will get the disease, because now she is having the disease. Now she is having mutated mitochondrial DNA. The same mitochondria are going to enter into the four children. So all the four children are going to get the disease. Okay. So now affected mother, right? Affected mother spreads disease to all offsprings. Okay, to all the offsprings. Affected mother. But for example, if a male is affected with these mitochondrial diseases, male affected, sir, I will show you. Okay. If a male is affected, then the father, affected father. Now father is having some mitochondrial disease, some problem in the mitochondrial DNA, some mitochondrial disease, sir. Okay. Now do you think he is going to spread the disease to the offspring? Is it possible? No, not possible. So affected father is not going to spread the disease. Okay, affected father do not spread the disease. Okay, do not spread the disease, sir. Okay, this is the point which I want you to know. Now, for example, see, now let's take this as a father. Okay, now father and mother. Father and mother. In the pedigree, here I am showing you mother is affected. Okay, mother is affected. Now, if this couple, if they have four children, tell me. Now, let's see, they are having two boy children and two girls. Okay, two daughters, two sons and two daughters. Now, how many of them will be affected? Sir, mother is having mitochondrial disease. If mother is having mitochondrial disease, now all these four offsprings are going to be affected. Okay, all these four offsprings are affected with the disease, sir. Which disease? I will discuss, don't worry. Now, let's say, now this daughter, now she married, okay, she married some other guy who is a healthy guy. Okay, now this son married some girl, healthy girl. Okay, now what happens? Dekho. Now what happens? See, now you should tell me, answer, try to answer yourself. Now they are having three children, two boys and one daughter. Now these people are also having same two boys, for example, two boys and one daughter. Now tell me, which children will be affected? See, here the father is affected, here the mother is affected. When the mother is affected, all the offspring will be affected. Okay, when the mother is affected, all the offspring will be affected. Okay, see here the father is affected with the mitochondrial disease, but the father is not contributing any mitochondrial DNA to the offsprings. He is not giving any mitochondrial DNA. So here all the children are healthy. So this is how the pedigree chart is going to come in your exam. Okay, look, mother affected, all children affected. Mother affected, all children affected. Then it is 100% mitochondrial disease, sir. Okay, mitochondrial disease. Now after this, what else I want you to know? Examples of mitochondrial disorders. Mitochondrial disorders. Now what are the examples? Come on, Farmod, do you know any examples? Do you have any idea? Farmod? Do you have any idea? Mitochondrial disorders? Now these are very important, especially for the Central Institute exams. Okay, especially for the PG exams, these mitochondrial disorders are very much important. Now let me write MELAS. MELAS is the first mitochondrial. It's the most common, sir. It's the most common mitochondrial disorder. First itself I am telling you, see, in all these mitochondrial disorders, sir, mitochondria are the sources. It's the source of ATP. Mitochondria is the place where ATP is getting generated. It's a powerhouse of our cells. So we need the ATP continuously, sir. Who needs ATP continuously? Especially our neurons. Our neurons need the ATP continuously. So in all these mitochondrial disorders, there will be neuropathy. Neuropathy. Okay, even the visions of our visual activity also continuously vision is happening, right? Electrical impulses are traveling. Okay, so even these people will have problems with the, like, eyes. Ophthalmoplegia is going to be seen. Okay. Okay, ophthalmoplegia and even vision loss can be seen, which is irreversible in nature. Irreversible vision loss can also occur. Okay, but generally speaking, there will be involvement of the nervous system and there will be also involvement of the eyes, because they continuously need the ATP. Now in these disorders, the mitochondria are affected, the ATP production is affected, oxidative phosphorylation is affected. So these patients will have neuropathies and ophthalmoplegias. Okay, now what exactly is MELA, sir, if you ask me? MELA means mitochondrial encephalopathy. See, encephalopathy, something involvement with the central nervous system. Mitochondrial encephalopathy, lactic acidosis. Okay, ME, mitochondrial encephalopathy, lactic acidosis. Okay, normal aerobic respiration is not going to be possible because now the mitochondria are affected. Normal aerobic respiration is not occurring. Anaerobic respiration, ATP is not synthesizing. So anaerobic way of glycolysis. Okay, so lactic acidosis, stroke-like episodes. Okay, so this is the full form of the MELAS. So these patients are going to have mitochondrial encephalopathy, lactic acidosis, stroke-like episodes. Now if you ask me, in one of the exams this question was asked, so these patients are going to have seizures, sir. These patients are going to have the seizures. Okay, so which seizures? The patients are going to have tonic-clonic seizures. Tonic-clonic seizures. Okay, the patients are going to have the tonic-clonic seizures, and apart from that, these patients are also going to have muscle weakness. Okay, so this is something important. These patients are going to have the tonic-clonic seizures. Okay, yes, guys, this is the first mitochondrial disorder. The second mitochondrial disorder which I want to discuss is CPEO. CPEO. So what exactly is CPEO? If you ask me, chronic progressive external ophthalmoplegia. Okay, chronic progressive external ophthalmoplegia. See, again, eye involvement. Okay, now this one more thing, the CPO means chronic progressive external ophthalmoplegia, and also this patient is going to have bilateral ptosis. Okay, bilateral ptosis is going to be seen. Okay, with bilateral ptosis. So this is the second mitochondrial disorder. Now the third mitochondrial disorder which I want you to know is Murph. Okay, MERRF, Murph. Guys, can you tell me what exactly is Murph? What exactly is Murph? Murph stands for Murph. It's the third mitochondrial disorder. Can you guys tell me what exactly is Murph? Murph means myoclonic epilepsy. Okay, myoclonic epilepsy, red ragged fibers. Okay, myoclonic epilepsy with the red ragged fibers. Now, in one of the exam, okay, especially this was asked in the Central Institute exam, and also this is very much important for your board exams. So those students who are trying to prepare for the USMLE exams, this was the question asked. So, what exactly happens in this Murph is the patient, okay, the patient is having point mutation, sir. Point mutation. Okay, where point mutation? On 8344th base pair. Okay, this is not the question. Okay, pair in mitochondrial DNA. So in the mitochondrial DNA, at this base pair, okay, 8344th base pair, there is a point mutation. Now, because of this, the patient is going to have which features? So features, clinical features, the patient is going to have are generalized seizures. Okay, the patient is going to have generalized seizures. The patient is going to suffer with dementia and also generalized seizures, dementia and cerebellar ataxia. Okay, so these are the three clinical features which I want you to know. So Murph, the patient, the Murph means myoclonus epilepsy, red ragged fibers. Now, if you ask me, sir, what exactly are these red rag fibers? I will show you the image. Okay, I will show you the image. See here. Now, see, this is the muscle biopsy. Okay, here is the muscle biopsy. Now, in the muscle biopsy, you can very clearly see this red color appearance. Okay, so these are the mitochondria. Okay, these are the mitochondria, sir. Okay, so in the muscle biopsy, you can very clearly see. This is very important image based question. Now, look here. On electron microscopy, here, this is the electron microscopy, sir. Okay, this is the electron microscopy. Now, whatever you can see here, all these are the mitochondria, damaged cristae. In the mitochondria, you know, right, the cristae are present. The cristae, the inner mitochondrial membrane forms the cristae. So, the damaged cristae, it is forming this disc-like appearance. Okay, it's forming a disc-like appearance. So, this is called as the abnormal mitochondria with circular damaged cristae forms a concentric membranous ring-like structures. This is called as phonographic records. Okay, phonographic records, sir. You know that phonograph, right? Like, you know, we'll put the phonographic disc to play the music. So these are the phonographic records. Okay, so phonographic records are seen in which condition? So they are seen in Murph, myoclonus epilepsy, red ragged fibers. And not only that, here you can see this mitochondria, inside the mitochondria, this cristae, they are arranged like a cars, like, you know, car parking. Okay, car parking areas. Okay, so look here, see, you can see the thick parallel rods inclusions. This is something called as a parking lot appearance or parking lot inclusions. Okay, the parking lot inclusions in the damaged mitochondria, you can see these inclusion bodies. They are called as a parking lot appearance. So for your exam, especially for the Central Institute exams, you should know phonographic records are seen. These red ragged fibers are nothing but the mitochondria. So these red ragged fibers, okay, whatever I am highlighting, this in the periphery of the muscle, these are the mitochondria. Okay, done. So after Murph, now let's go with the NARP. NARP. So I want you to answer. Come on, guys. Come on. What exactly is NARP? Any idea? NARP. NARP. NARP stands for, yes, neurogenic ataxia retinitis pigmentosa. Okay. Neurogenic ataxia. Okay, neurogenic ataxia retinitis pigmentosa. Next, mitochondrial disease. Not much important points about the NARP. Next mitochondrial disease is LON. What exactly is LON? Leber's hereditary optic neuropathy. So Leber's hereditary optic neuropathy. Now here important point which I want you to know is for the Central Institute exams. So here in this Leber's hereditary optic neuropathy, the complex 1 in the mitochondria, you know, right, the complex 1 which is involved in the formation, like, you know, of the ATP, complex 1, 2, 3, 4. So complex 1 is damaged, okay, because of the mitochondrial genes which are mutated. The complex 1 dysfunction is seen. There is a dysfunction of the complex 1, and even there is optic death. Okay, I should say the cellular death in the optic nerve, MCQ. Okay, cellular death in optic nerve, or they can say optic nerve atrophy. Okay, optic nerve atrophy. So in this condition especially the Leber's hereditary optic neuropathy, see in the name itself it's there, there is optic neuropathy. The patients are going to have acute, means sudden, acute or subacute vision loss. So just tell me one mitochondrial disorder which presents with irreversible vision loss, that is Leber's hereditary optic neuropathy, where there is complex 1 dysfunction, optic nerve is going to be damaged. There is cellular death in the optic nerve that will cause acute or subacute visual loss. Okay. Now, last one which I want you to know is, okay, Leigh syndrome. Okay. Okay, Leigh syndrome, sir. Sir, what exactly happens in this Leigh syndrome? So the genes mutated. Okay, Central Institute exams important. The genes mutated are SURF SURF. SURF1 gene is mutated in 80% of the cases. In 80% of the cases, the gene mutation is SURF1 gene mutation. In 20% of the cases, the gene mutation is MTATP6. Okay, MTATP6 gene mutation in 20% of the cases. In 20% of the cases. Now, because of these gene mutations, again there is dysfunction. Dysfunction of complex 1 of the mitochondria. Okay, again there is dysfunction of the complex 1 of the mitochondria. So in this condition, okay, in this condition, Leigh syndrome, what are the clinical features? Any idea, guys? What are the clinical features seen in this condition? Sir, Leigh syndrome, what are the main clinical features? The patient are going to have, yes, visual involvement will be there, definitely the central nervous system involvement will be there, and the muscle involvement is going to be there. Now, any eye abnormalities, can you tell me? Sir, this mitochondrial disorder, it's going to present with nystagmus, sir. Okay, nystagmus movement. Okay, nystagmus is going to be seen. True, one thing. And in this condition also, optic nerve atrophy. Okay, optic nerve atrophy is going to be seen. True. And in this condition, very important MCQ. Okay, these patients are going to have hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is seen. So in which mitochondrial diseases hypertrophic cardiomyopathy is seen? See, go for the Leigh syndrome. Okay, here the patient is going to have the hypertrophic cardiomyopathy. Apart from this, the patient is going to have ataxia, and the patient is also going to have the neurological involvement, that is the psychomotor regression is going to be seen. Okay, regression, psychomotor regression, and these patients, it's very hard for them to survive. Okay, failure to thrive. Failure to thrive. So one important point which I want you to know here is this one, sir. So the MCQ point is hypertrophic cardiomyopathy. Okay, nystagmus, hypertrophic cardiomyopathy, ataxia, psychomotor regression, failure to thrive. These are all the features of Leigh syndrome. The gene mutations are SURF1 gene mutation and MTATP6 gene mutation. The mutation in these two genes can lead to the dysfunction in the complex number 1. Complex number 1, sir. Okay. So with this, Leigh syndrome is also completed. So which syndromes we have discussed? MELAS, mitochondrial encephalopathy, lactic acidosis, stroke-like episodes. Okay, the patients are going to have the tonic-clonic seizures. In CPEO, chronic progressive external ophthalmoplegia with bilateral ptosis. Murph, very much important. Image-based questions are very much important, sir. Here, the muscle biopsy is showing the red ragged fibers, and electron microscopy is showing the phonographic records as well as the parking lot appearance. Parking lot appearance because of the inclusion bodies. And after this, what we have discussed, Murph completed. After this, NRAPP, neurogenic ataxia retinitis pigmentosa. LON means Leber's hereditary optic neuropathy, where there is sudden acute or subacute visual loss is going to be seen because of dysfunction in the complex number 1. And Leigh syndrome, SURF gene mutation as well as MTATP6 gene mutation, done, sir. Now after this, there are even other mitochondrial diseases present. Let me tell you one more. Pearson. Okay, Pearson syndrome. Okay, so Pearson syndrome is also a mitochondrial disease, same mitochondrial disease. Now can you guys tell me, it's now your turn, sir. See, tell me, in Pearson's syndrome, the patient is going to have which involvement? Guys, do you have any idea? Guys? Come on, fun mode. Bria, Punya, fun mode. Do you guys have any idea? Pearson's. See, I used to remember P for P. The patient is going to have pancreatic insufficiency. Okay, the patient is going to have the pancreatic insufficiency as well as, very important, the second thing, sideroblastic anemia. Okay, so pancreatic insufficiency as well as sideroblastic anemia. So just as a recap, tell me, what are the important mitochondrial diseases? The important mitochondrial diseases are MELAS, CPO, Murph, NRAPP, Leber's hereditary optic neuropathy, Leigh syndrome, and Pearson's syndrome. Okay, Pearson's syndrome, sir. Okay, now after this, let's discuss about the mitochondrial diseases completed, sir. I have shown you the mitochondrial inheritance pattern also. If mothers are affected, all offsprings are affected. If the father is affected, no offspring is going to be affected. Now after this, the next topic which I want you to know is trinucleotide repeat disorders. Okay. Now, so do you know any trinucleotide repeat disorders? Normally in these disorders, what happens, sir? Simple. What happens, sir? The trinucleotide repeats in the DNA. The trinucleotide repeats, for example, CAA or CAG, CAG. So this is a trinucleotide, right? You know, 3 nucleotides together called as a trinucleotide. So these trinucleotides are going to repeat. Okay, thousands and thousands of times. The same trinucleotide repeat is going to repeat again and again. Okay, normally it should be CAG, CAA, CGA, something like that, CTG, something like that. Okay, but now what happens in this trinucleotide repeat disorder, sir? For example, now imagine this is the DNA. Now in this DNA, now the same repeats are going to, same trinucleotides are going to repeat. CAG, CAG. Again, one more, CAG. Cysteine, adenine, guanine. Again, cysteine, adenine, guanine. Cysteine, adenine, guanine. Normally, yes, these repeats are there in our DNA, but these more number of repeats are going to occur. Again and again. So that's going to cause a disease, sir. Okay. So now, first let's see what are the trinucleotide repeat disorders. There are 4 important trinucleotide repeat disorders. One is Huntington's. Okay, Huntington's disease. Next, Fragile X Syndrome. Next, Friedreich Ataxia. And last one is Myotonic dystrophy. So these are the 4 disorders which are due to trinucleotide repeats, more number of trinucleotide repeats. Now in your exam, if you are going for your FMGE exam, now this is the least which you should know. The least which you should know is, sir, in Huntington disease, yes, it's a trinucleotide repeat disorder. Which trinucleotides are going to repeat again and again? Remember, it is CAG, CAG repeats. Okay, the same CAG is going to repeat again and again. Sir, in Fragile X Syndrome, what is the trinucleotide repeat that's going to occur again and again? It is CGG repeats. Okay, CGG, sir. Now in Friedreich Ataxia, I used to remember something like this. Ataxia means what? Ataxia means gait abnormality, right? Gait abnormality. Gait. So gait is not proper. So here the repeats are GAA. Okay, GAA, gait, right? GAA. I used to gait, GAA. Right, gait. I used to remember something like that. So GAA repeats are going to occur again and again. Sir, myotonic dystrophy. I used to remember myotonic dystrophy. So tonic, T. So CTG. So everything. Okay. See, in most of the things it's starting with the same C, sir. C. Here also C. Everything starts with the CCC and even ending with G. Easy, I have given you mnemonic. Sir, this one. Wait, yeah, this one. Ataxia, Friedreich Ataxia. Ataxia means gait, GAA. But everything starts with C. Everything is going to end with the same G. So now tell me, Huntington's disease, what are the repeats going to occur? CAG, CAG repeats, Fragile X Syndrome, CGG, and Friedreich Ataxia, GAA, and the myotonic dystrophy, it is CTG. These are the disorders. Now look here. First, let's discuss about the Fragile X Syndrome. Okay, Fragile X Syndrome. Okay, the Fragile X Syndrome, sir. Now, look, this is a normal X chromosome. This is your normal X chromosome. Now, if you look here, in this Fragile X Syndrome, Look here, it's just looking like that part of this X chromosome, it is falling off. Okay, this part of X chromosome, it is getting separated, detached. It's very much a fragile area. So there is this fragile area. Why that fragile area? It's because of, like, that area is going to be not stained, sir. That area is not going to take the stain. Okay, when you stain that chromosome, that particular part of the chromosome is not going to take a stain. So that it's looking like it's a fragile region. Okay, so Fragile X syndrome. Now tell me, in Fragile X syndrome, what are the important points which you need to know? Sir, what is the gene mutation? Gene mutation. It is FMR1 gene mutation. If it's a FMR1 gene mutation, FMR stands for familial mental retardation. So it's a familial mental retardation, one gene is going to be mutated, and you already know in this Fragile X syndrome, what are the repeats? What are the trinucleotide repeats that are going to occur? So it's in Fragile X syndrome, it is not CTG. Just wait. So in this Fragile X syndrome, it is CGG. Yeah. Okay, CGG repeats are going to occur. Now look here. So these are the patients. Okay, these are the patients who are suffering with the Fragile X syndrome. Now in this Fragile X syndrome, okay, in this Fragile X syndrome, what are the important points which you need to know? Sir, okay, CGG repeats are there. Okay, how many repeats can actually cause the disease? Dekho, in you and me, in most of us, the CGG repeats less than 55 is considered as normal. Some books mention less than 45 is normal, but less than 55 repeats. If we have 55 repeats, that's okay. In you and me, we have the same repeats, sir. Same repeats. CGG repeats are going to be 55. That's okay. Now, more than 55 to 200. More than 55 to 200. That's considered as a premutation. Okay. Premutation. Now, when you are having this premutation, then you are going to suffer with, guys, remember, then you are going to suffer with Fragile X tremors, not Fragile X syndrome. Then you are going to have Fragile X tremors. Okay, it's a premutation, sir. Now, if you have more than 200 repeats, then it will cause a Fragile X syndrome. Then it's going to cause a Fragile X syndrome. Now, important points, guys, look here. These are the patients who are having the Fragile X syndrome. Look at their face. How their face is? Long face, long ears, long mandible. Okay, long face, long ears, long mandible. But one important point especially for your exam is, if you look at their nose is normal. What is normal? N for N. Nose is going to be normal, but they are going to have elongated long face with long ears and long mandible, sir. Okay. Now, apart from this, what else are the important points which you need to know regarding the Fragile X syndrome? See, these patients post-pubertal means once they reach their puberty, their testicular size is going to increase very much. So there is a macroarchidism. Okay, large testis. Okay, which is called as a macroarchidism. Apart from this, what else? So these patients are going to have, CVS problem, sir. Which is CVS problem? So these patients are going to have mitral valve prolapse. Okay, what is the CVS problem? It's a mitral valve prolapse. So that these patients can also have the mid-systolic clicks, okay, murmur. Because of this mitral valve prolapse, that's a mid-systolic clicks. These patients are going to have, enlarged, okay, and the dental crowding will be seen. That's not that important. I am not going into little small details. No, not enough. It's not needed. So post-pubertal macroorganism is seen. See, as a CVS abnormality, mitral valve prolapse can be seen. Okay, cardiomegaly can be seen, dilation of the aorta can be seen in these persons, but that's not important. Important point is, sir, I have shown you here the four fellows who are suffering with Fragile X syndrome. All these four fellows are the males. Why? Why Fragile X syndrome? All the persons who are getting affected are males, because Fragile X syndrome, remember, it is X-linked recessive disorder. It's an X-linked recessive disorder. Okay, sir, all these X-linked recessive disorders, okay, it's an X-linked recessive disorder, sir. All X-linked recessive disorders are going to occur mainly for the males. Then what are the females? Females are the carriers. Females usually do not affect with the Fragile X syndrome. Females are carriers. And these females can also have problem. Do you know what is that? Important MCQ. So these females will have premature ovarian failure. Okay, premature ovarian failure, sir. Okay, so whenever you see a question with a large face, elongated face, large mandible, with large ears, but the nose size is normal, with the mitral valve prolapse, okay, mitral valve prolapse with the murmurs, you should think about this patient is having Fragile X syndrome. And they can ask you in image based question also, okay, like they can give you X chromosome something like this with this other with these ends which are like little getting detached from the chromosome. Okay, so these are the Fragile X syndrome, which repeats. CGG repeats. More than how many number of repeats? More than 200 repeats. Okay, more than 200 repeats. In females, you can have premature ovarian failure. Premature ovarian failure. Now, after this, what else I want you to know is, let me write here, there is something called as Shermans Paradox. Sir, what exactly is this Shermans Paradox? This Shermans Paradox means, now the father is going to give this disease to the son. Imagine, a father is giving the disease to the son. Now, this son is going to give the disease to his son. Now, with generation to generation, this generation to generation, this disease is spreading, right? Now, do you know what happened to the number of trinucleotide repeats? So, with every generation, right? With every generation, for example, imagine there is his father. Okay, father is giving the disease to his son. This father is again giving the disease to son. Now, with, for example, he is having how many repeats? For example, he is having 500 repeats in CGG. Now, in this fellow, in this son, he is going to have 600 repeats. Now, in his son, he is going to have 750 repeats. Means with every generation, right? With every generation, number of repeats increases and severity of the disease also increases. Okay, so severity also increases, and you can expect, for example, if the father have manifested the disease at 30 years of age, now you can expect, you can anticipate, okay, you can anticipate that in the son who is having the same disease, he will develop the disease by 25 years, because the number of repeats are going to increase. The number of repeats are going to increase, the severity of the disease is going to increase, so that you can do anticipation. So, right, important MCQ, anticipation. Okay, anticipation is seen in the trinucleotide repeat disorders. Okay, with every generation, the number of repeats increases, severity of the disease also increases. So, you can anticipate that if the father is having a disease by 30 years of age, he will also develop, the son is also going to develop the disease a little earlier, okay, by 27 years of age or 25 years of age. Okay, so that's the Sherman's paradox. Now, after this, let me show you, this is the Netter's image. Okay, this is the Netter's image. You need to identify what is this disease. So, the disease where, see, once the patient is having a grip, now when you give something into his hands, he is going to have a grip, but see, he is having a contraction, muscular contraction is possible, but the relaxation is not possible, sir. See, difficulty in releasing the grip, difficulty in releasing the grasp or the grip, sir. So, guys, can you tell me what is this disease? Guys, can you tell me what is this disease? So this is myotonic dystrophy. Okay. Let me write here itself myotonic dystrophy. Okay, myotonic dystrophy, sir. Now, in this myotonic dystrophy, what are the important points which you need to know for your exam? Okay, myotonic dystrophy. Sir, what are the repeats? Myotonic, remember, myotonic, it's a CTG. Okay, CTG repeats. The repeats are going to be CTG repeats. See, this myotonic dystrophy, it follows which inheritance pattern? Autosomal dominant inheritance pattern. It follows autosomal dominant inheritance pattern. Important points about this disease. So these patients who are having this myotonic dystrophy, they have difficulty in releasing the grip or the grasp. Okay, difficulty in releasing the grasp. And if you look at their eyes, these patients are going to have the cataract. So this is the cataract. It's looking like a Christmas tree. Okay, it's looking like a Christmas tree. Okay, lightened Christmas tree. So these are called as, any idea? Christmas tree. Cataract. Okay, they are going to have the Christmas tree cataract. Apart from this, what else you should know? Sir, in this disorder, myotonic dystrophy, look at this person. Okay, yes, difficulty in grasp, okay. But if you look at this person, now he is having baldness, sir, male pattern baldness, very important. So male pattern baldness are going to be seen, and these patients are going to have, okay, hatchet faces. Okay, these patients are going to have the hatchet faces, something like this. Something like this. Okay, hatchet faces is going to be seen. So these are the two important points. Whenever you see the word hatchet faces, you need to think about myotonic dystrophy. Okay. And these patients are going to have the male pattern baldness. Okay. Now, very much important point. In which disease? In which disease? Today we have discussed. The patient is having macroarchidism, post-pubertal macroarchidism is seen in. Just now we have discussed here. Dekho. Look here. See, large testes, macroarchidism, it is seen in Fragile X syndrome, But now in this myotonic dystrophy, the patient is going to have the testicular atrophy, MCQ. This is the MCQ, sir. Testicular atrophy. Okay, testicular atrophy is going to be seen, sir. Apart from this, any other important point for your exam? Yes, there is one important point for your exam, that is the patient is going to have the cardiomyopathies, arrhythmias. Arrhythmias, cardiomyopathies with the heart blocks. Okay, so these are the important points which I want you to know. So myotonic dystrophy, important points, see, autosomal dominant disorder, myotonic, so CTG repeats are going to be seen. So difficulty, these patients are going to have the difficulty in releasing the grasp, contraction okay, but relaxation is not possible, difficulty in releasing the grasp. Christmas tree cataracts are going to be seen. The patients are going to have the hatchet faces, long elongated hatchet faces are going to be seen. Male pattern baldness, testicular atrophy is going to be seen with arrhythmias. The cardiovascular involvement is going to be the arrhythmias and conduction blocks. Cardiomyopathies, conduction blocks are going to be seen. And in these patients, the patient is also going to have the muscular atrophy, myotonic dystrophy, right? So muscular atrophy, important point. These patients are going to suffer with muscular atrophy and respiratory difficulty, because even the diaphragm is a muscle. It's also having a problem now. So there is respiratory difficulties. So all these are the important points which I want you to know. At least before going to your exam, remember this testicular atrophy, male pattern baldness, Hatchet facies, Christmas tree cataract, and CTG repeats. Okay, everything is a question. I cannot say, like, I cannot give you the discounts here. Okay, CTG repeats important, autosomal dominant important, difficulties in releasing the grip. This is a very important keyword. Okay, so these are the points which I want you to know. Now, completed, sir. Trinucleotide repeat diseases, important points I have completed. Now, after this, let's discuss about the genomic imprinting. Genomic imprinting. So what exactly is this genomic imprinting, sir? What is the concept of genomic imprinting? Okay, let me tell you. Look here. First of all, guys, can you tell me what is this baby suffering from? There is this baby who is having a short stature and obese. Short stature and obesity. Okay. Now, do you know he is suffering with which genetic abnormality? I will tell you. Okay, I will tell you. But before going there, you need to understand what is genomic imprinting, sir. Now, let me take chromosome number 15. Okay, chromosome number 15. So 15 chromosomes, 215 chromosomes. So we all have the 215 chromosomes, right? One from the mother, one from the mother, other from the father. Father, mother. So I have two chromosome number 15s, one from the mother and one from the father. Now the first gene I want to discuss here is called as a SNRP gene. Okay, the gene which I want to discuss here is called as a SNRP gene. So this SNRP gene, where it is present? Sir, it is present both, for example, let's see, for understanding purpose I am keeping here. Okay, the SNRP gene is present both in mother as well as father. So this SNRP gene which is present in the mother, it is silenced. It's by methylation process. By doing the methylation, by adding the methyl group to these genes, it is completely silenced, sir. It is silenced, means it is sleeping. The SNRP gene which is present in the father, the SNRP gene which is present in the father, it is active. Means by default normally itself, the SNRP gene which is present on my maternal chromosome, it is totally silenced. Normally how it should be, according to Mendel, see, according to Mendel, there are two sets of genes, one from mother and one from the father. Two alleles, one from father and from the mother. Same gene is having two alleles, one is on the mother, one is on the father. Now, whoever is dominant, whoever the gene is dominant, okay, so that gene is going to be expressed. Whatever the gene is dominant, that gene is going to be expressed. Other gene is going to be not expressed. But in this condition, see, this is not following the Mendel's law. Yes, two genes are there, two SNRP genes are there. By default itself, all our maternal SNRP genes are silenced. So, which SNRP gene is active? Only paternal side SNRP gene is active. Okay, one is silenced, one is active. Done. Now, let me tell you about the one more gene, sir. Okay, one more gene. Now, same 15 chromosome. This is the same 15 chromosome. One from the father and one from the mother. 15 chromosome from the father, 15 chromosome from the mother. Now, I am talking about a gene which is called as UBE3A gene. Okay, UBE3A gene. So, is it important for your exam? Yes, especially for the PG exam. This is very much important. SNRP gene, UBE3A gene. Now, same genes are present both on mother as well as father also. Same gene is present. But in the mother, this UBE3A gene, okay, it is active. It is active. Active means it is going to express. It is going to be expressed. But here, this UBE3A gene on the father, these genes are methylated. By doing this process of methylation, the genes are going to be totally silenced. So, gene silencing, how can you do? By doing methylation. By doing methylation, sir. Now, silenced. Okay, silenced. Now, what happens? This is something normal. What happens? Now, dekho, what happens in Klinefelter syndrome? Okay, what happens if there is some problem? Okay, not Klinefelter syndrome, sorry. What happens if there is any problem with this imprinting process? First, let's write the diseases here. The two diseases which I want to discuss here is Prader-Willi syndrome and Angelman. Okay, so Prader-Willi syndrome as well as the Angelman syndrome. So what is the problem in the Prader-Willi syndrome? Problem क्या है Prader-Willi syndrome में and Angelman syndrome? See, look here. Normally, the SNRP genes. So SNRP genes are active. Okay, SNRP genes are active in the paternal chromosome, but the SNRP genes are totally silenced in the maternal chromosome. Now, what happens if there is a deletion of this paternal chromosome? Paternal chromosome is gone, deletion. So now I am left with only maternal chromosome number 15. On maternal chromosome number 15, the SNRP genes are not active, they are silenced. So I completely lost the SNRP genes. Okay, so Prader-Willi syndrome, what is the problem? Let me write here. The problem in Prader-Willi syndrome, how can you get the Prader-Willi syndrome? Is one way. I am telling you what is the one way. It is paternal deletion, paternal chromosome number 15 deletion. So deletion of paternal chromosome, or try to understand like this. There is one more possibility, Prader-Willi for P. See, remember simply Prader-Willi, paternal deletion of chromosome number 15. Now one more possibility how you can get Prader-Willi syndrome is, imagine now as a person you are supposed to have, as a human you are supposed to have 215 chromosomes. 215 chromosomes, one from the father as well as one from the father, one from the mother. Okay, one from the father and one from the mother. What if you got chromosome number 15, both the chromosome number 15 from the mother itself? From the mother you got two 15 number chromosomes. Father is not donating the 15 number chromosome. This is called as uniparental disomy. Uniparental disomy, which means uniparental, from one parent 215 chromosomes came from where? Mother. So maternal disomy. So maternal disomy of chromosome number 15. Now you already know, sir, if both the chromosomes come from the mother, 15 number chromosomes, in the mother you know that the SNRP genes are completely silenced. The SNRP genes are completely silenced because of the methylation. So the SNRP genes are not going to be active in you. So that's going to cause which syndrome? That's going to cause the Prader-Willi syndrome. So now tell me in your exams, these are the questions. So the Prader-Willi syndrome is due to paternal 15 deletion, or you can get the same Prader-Willi syndrome because of the maternal disomy 15. Maternal disomy 15. Now, then what is the Angelman syndrome, sir? In Angelman syndrome, what is the problem? Sir, in Angelman syndrome, the problem is, again, look here, UBE3A gene. UBE3A gene. So, this UBE3A genes, they are active only on the maternal chromosome number 15. Maternal chromosome number 15. What if you lost the maternal chromosome? Deletion of chromosome number 15 from maternal chromosome number 15. Now this UBE3A genes, yes, they are also present on the father side, but they are inactive. So you completely lost those genes. So in Angelman syndrome, what is the problem is a maternal 15 deletion. So deletion of chromosome number 15, which came from the mother. So maternal 15 chromosome is lost. So then it's going to cause Angelman syndrome. Or you can get the Angelman syndrome. How you will get the Angelman syndrome? If you receive chromosome number 15, two copies of chromosome number 15, both from the father. Okay, so that is paternal disomy. Paternal disomy 15. If you get both the 15 number chromosomes from the father, then you do not have functional UBE3A genes. They are not there in your body. So then you are going to get the Angelman syndrome. So the important points I have give you about the Prader-Willi syndrome and Angelman syndrome. Prader-Willi, Prader, P for P, paternal deletion of chromosome number 15. Angelman syndrome is the maternal, angel is the mother. Deletion of chromosome number 15 from the mother is going to cause the Angelman. And one more possibility also I explained you, that uniparental disomies can also lead to the Prader-Willi as well as Angelmans. Now in Prader-Willi, dekho, sir, in Prader-Willi syndrome, let me write here important points about the Prader-Willi. In Prader-Willi syndrome, what are the clinical features, sir? See, this is the guy who is suffering with the Prader-Willi syndrome. Now what are the clinical features are going to be seen? First clinical feature number 1, so Prader-Willi syndrome clinical features, short stature. Okay, short stature. Second, obesity. Okay, obesity is going to be seen. So these patients are going to have hyperphagia, excessive, they can't control, their eating habits. There will be hyperphagia. Hyperphagia is going to be seen. They are going to have hypotonia in the muscles. Okay, the muscles are going to show the hypotonia. their body skin color is also going to be very much fair, hypopigmentation. Okay, 3H, H. Okay, there is a mnemonic that is H30. Okay, H30. Okay, H30 is the mnemonic, sir. H30. H for H3, 3 H's, sir. These patients are going to have the hyperphagia, hyperphagia, hypotonia, as well as hypopigmentation. O for obesity. These patients are going to have, like, obesity, short stature and obesity. Now, in these patients, there is, why obesity means they have high levels of ghrelin. Okay. Sir, the ghrelin levels, it causes the hunger, sir. Okay, it causes the hunger. So these patients are going to have a low impulse control. They cannot control their eating. They will be doing hyperphagia, sir. Low impulse control, very important MCQ. Low impulse control. Okay, so they cannot control their food habits. Okay, so that's a low impulse control because of the high levels of ghrelin hormone. Ghrelin increases the hunger. Normally in you and me, ghrelin is produced during fasting states by the pancreas. Okay, pancreas, the epsilon cells of the pancreas are going to produce the ghrelin. Ghrelin increases the hunger, we know it. But in which genetic disorder, the ghrelin levels are going to be elevated. The patient is going to have short stature, obesity, hyperphagia, low impulse control, hypotonia with hypopigmentation. All this is the Prader-Willi syndrome. Prader-Willi syndrome is because of what? Prader-Willi syndrome is because of the deletion of chromosome number 15. Paternal deletion. Now, Now, what are the important points about the Angelman syndrome? Now, look at the Angelman syndrome. So, this Angelman syndrome, these babies, for example, this female, now she had Angelman syndrome. Now, whenever you look at this Angelman babies, they are going to have this uncontrollable laughter. Okay, they are going to have this weird smiling. Okay, weird smiling. So these Angelman babies, they are called as happy puppets. Okay, they are called as happy puppets, sir. They are called as happy puppets. They are having this uncontrollable laughter, sir. Okay, that's the one important point which I want you to know. See, they are having this weird smile. Okay, weird smile is going to be there. And one more important point is, sir, these patients are going to have the main problem for these patients is seizures. Angelman syndrome. So seizures are going to be there, uncontrollable laughter is going to be there, and these patients are usually mentally retarded. Okay, mentally retarded, sir. Intellectual disability is going to be seen. So image based question, this is the Prader-Willi boy. Okay, and this girl is having that uncontrollable laughter. She is having Angelman syndrome. So just a recap. Sir, SNRP genes are active. Remember, the SNRP genes are active in father. There is maternal silencing. And how do you do silencing? MCQ. Silencing is done by doing methylation and UBE3A genes. Okay, UBE3A genes. So the UBE3A genes, they are silenced in the father by doing methylation. UBE3A genes are active only in mother. Okay, so this is done, sir. We have also completed the topic of genomic imprinting. So now completed the important non-Mendelian disorders, the non-Mendelian inheritance, completed, sir. Now after this, guys, can you tell me this image based question, what exactly are we discussing? Now by looking at this image, can you tell me, sir, this baby, this female, is she suffering with which condition? Can you tell me? Sir, actually now we are going to discuss about the chromosomal disorders. Means now we are not talking about the genes, sir. We are not going to talk about the genes. Entire chromosomes, the chromosome is deleted, or having an extra chromosome. We are not talking about the single genes. We are not talking about the point mutations. We are talking about the entire chromosomal problems. Chromosome got deleted, chromosome have inverted, translocations, deletions, insertions. We are going to discuss about them. Okay, now, so the first disorder which I want to discuss is Down syndrome, sir. Okay, Down syndrome. Now, my questions to you. So this Down syndrome is because of which chromosomal abnormality? What is the chromosomal abnormality seen in the Down syndrome? It's a trisomy. Trisomy what? Trisomy 21. Trisomy 21 means there is an extra 21 chromosome. Okay, there is extra 21 chromosome. Normally, देखो, in your cells, how many 21 chromosomes are supposed to be there? Sir, there are supposed to be 2 chromosomes, 21 chromosomes, one from the mother, one from the father. But if you get one extra 21 chromosome, sir, then it is going to cause Down syndrome. That's the trisomy 21, extra 21 chromosome. Now, what are the causes? Why Down syndrome? Why? So, the most important risk factor, let me write here, risk factor is increase in maternal age. Increase in the maternal age, which means now this female is 35 years or 37 years. Now at this age, if she is trying to conceive, if she is trying to have a baby, that baby might develop, or that baby might get this Down syndrome, sir, Down syndrome. So the causes, important cause is the non-disjunction. Okay, meiotic non-disjunction, sir. Okay. Meiotic non-disjunction in 95% of the cases. During meiosis, normally the chromosomes are supposed to separate, right? The chromosomes are supposed to separate. Okay, during meiosis, the chromosomes number should cut down into half, should become half. Okay, the 46 chromosomes should split, and it should, like in one cell 23 chromosomes, and into the other cell 23 chromosomes. It should be segregated. But non-disjunction, this 21 chromosome is not separating. Okay, so in one single cell, let me put it this way for your understanding. Sir, now there is this ovum. Okay, ova. Now in this ova, there are 221 chromosomes. 221 chromosomes. Sir, mother is giving the ova, and in this ova, there are 221 chromosomes. Why? Because the chromosomes are not separated, not split into two halves. Actually, there should be only 121 chromosome, but here there are 221 chromosomes. Now such an ovum, if it is fertilized by a sperm, sir, this is the sperm, sir. Now even sperm have 121 chromosome. Now tell me what happens. Sir, here 2 chromosomes. Now here 121 chromosome. Now what happens in the zygote? Sir, in the zygote there will be, and the baby there will be 321 chromosomes. Okay, that's a non-disjunction. Maternal non-disjunction, sir. Maternal. So mother age is increasing. So her meiosis, like her oocytes, the quality of the oocytes she is producing, they will gradually decrease. The quality decreases. There will be more and more non-disjunctions that are happening. Because of this non-disjunction, there can be Down syndrome. 95% of the cases, there is a maternal non-disjunction during meiosis. Other cases includes, okay, Robertsonian, translocation, which is accounting for 4% of the cases, Robertsonian translocation, or mitotic non-disjunction. Mitotic non-disjunction can also lead to Down syndrome, but only in very few conditions, sir. Very few conditions, 1% of the cases. Now you need to know the most important for your FMGE exams, the most important point, and for the NEET PG exam also, is the non-disjunction of maternal 21 chromosome during meiosis, accounting for 95% of the cases. Okay, that's the important point I want you to know. So after this, sir, how the Down's babies are going to be? If you look at the Down's babies, what are the clinical features that are seen? Now look here, this is the Down's baby. Now what you can appreciate is a big tongue that is protruding out. Okay, that's a macroglossia you can see. Now if you look at their the babies, if you look at their legs, you can see a very much gap between the toe and the other fingers. This is called as saddle toes. Okay, saddle toes. And if you look at their eyes, you can see in the iris there are the spots seen. These are called as brush field spots. Next, if you look at their hands, there will be one single line. This is called as palmar simian crease. Okay, palmar simian crease is going to be seen. Now let's try the clinical features, sir, one by one. One by one, clinical features. The clinical features are going to be, first clinical feature number 1, there will be mental retardation, Now, not only this, remember, for your entire life, remember, Downs, Edwards, Patau, all the chromosomal disorders are going to have the mental retardation, no doubt. Not just the Downs, but also Edwards, Patau, Trinucleotide, all the chromosomal disorders are going to present with the mental retardation. And this Downs is the most common cause of mental retardation. Okay, Downs is the most common cause of mental retardation in the chromosomal disorders. Okay, most common cause of mental retardation. Next, these patients are going to have macro. We have seen glossia. Okay guys, macroglossia, the big tongue is going to be seen. In the eyes, what you have seen? It's the brush-filled spots. Next, palmar, simian, crease. Okay, palmar, simian crease. Okay, palmar simian crease is going to be seen. Next, what else? If you look at their eyes, okay, brush-filled spots are seen, but if you look at their eyes, so there will be upslanting palpebral fissures. Okay, their eyes will be slanting like this. Okay, so if you look at their eyes, they are little like this. Okay, there will be upslanting. Palpebral fissures. And if you look at their nose, the nose is going to be flat. Okay, in the nasal bridge, the nasal bridge is going to be flat, sir. Flat nasal bridge. Okay, the nasal bridge is going to be flat. And what else we have missed? In the toes, saddle toe. Saddle toe is going to be same. They are going to have the saddle toe. So macroglossia, brush-filled spots, palmar simian crease, oblique palpebral fissures, flat nasal bridge, and they are going to have the saddle toes. And you can say, like, we can put many more points, like, their faces are going to be like mongoloid faces. Okay, mongoloid faces, like, ape-like. Okay, mongoloid faces. Okay, so all these are the important points which I want you to know regarding the Down syndrome. Apart from this, so if I am having Down syndrome, okay, the external features I have explained. Internally, sir, which diseases I can get? What are the problems with the cardiovascular system? What are the problems with the blood? What are the problems with the, different organ systems, kidneys and GIT? Now, diseases associated with Downs. See, these Downs patients, by age of 40 years, by the time they reach their 40 years, okay, 30, 40 years, some books mentions 30 and some books mentions 40. By the time they reach 40 years, all these Downs patients, they are going to develop Alzheimer's disease. That's the dementia, sir. They will develop this Alzheimer's disease. This is the one important point I want to know. In cardiovascular system, okay, what is the cardiovascular problem? So these patients are going to have congenital anomalies. The serious congenital anomalies, endocardial cushion defects. Endocardial cushion defects. Endocardial cushion defects are going to be seen. Next, GIT abnormalities. These patients will have its sprung disease. That is a congenital megacolon, Hirschsprung disease. And in GIT, these Downs babies, they will develop the duodenal atresia. Okay, duodenal atresia, sir. So this is a very important MCQ. The Down syndrome patients are going to develop the duodenal atresia and radiological sign. On radiology, how the duodenal atresia is going to look like? Double bubble appearance. Double bubble appearance, sir. Okay, and we have completed the Alzheimer's disease, endocardial cushion defects are completed, GIT abnormalities completed. Now, hematological abnormalities. See, the point which I want you to know is the most common, if you ask me, the most common hematological abnormality. Do you know? So what is the most common hematological abnormality? The most common hematological abnormality is seen in the Downs patients. Do you have any idea, guys, what is the most common hematological abnormality that is seen? It's a transient, see, it's not a cancer, sir. It's a transient abnormal myelopoiesis. Transient abnormal myelopoiesis. Transient abnormal myelopoiesis is the most common hematological abnormality that is seen. But if they ask you, okay, in Down syndrome, what are the cancers? Okay, the blood cancers, which blood cancers are most common? Before 3 years, okay, this is very important. Before 3 years of age, what is the most common cancer that they will develop? It is acute megakaryoblast leukemia. Okay, acute megakaryoblast leukemia. Okay, acute megakaryoblast leukemia. After 5 years, which cancer they can develop? Okay, which blood cancer they can develop is ALL, acute lymphoblastic leukemia. Okay, ALL, acute lymphoblastic leukemia after 5 years of age. Before 3 years of age, the most common cancer that they can develop is acute megakaryoblast leukemia. Okay, acute megakaryoblast leukemia, sir. These are the problems which are seen, these are the diseases which are associated with the Down syndrome. Okay, Alzheimer's disease, endocardial cushion defects, Hirschsprung disease, renal atresia. Most common hematological abnormality is a transient abnormal myelopoiesis. Before 3 years, it is acute megakaryoblast leukemia. After 5 years, it is acute lymphoblastic leukemia, sir. Now, in your exams, what else they can ask you is, देखो, screening tests. Okay, screening test. Now imagine there is this one female. Now she is trying to conceive. She is trying to have a baby at 38 weeks. Sorry, not 38 weeks. At 38 years. Okay. Now she is 38 years, and now she is trying to have a baby. Now you know, increase in maternal age is risk factor for development of the Down syndrome. You know it. Now you want to know whether the baby, okay, that she is having, the baby is suffering with the Downs or not. You just want to know it. So what you will do? So you are going to order for ultrasonography, right? Ultrasonography. So in ultrasonography, what you can see, okay, in ultrasonography, okay, actually I just kept an image. I forgot. Okay, I think it was deleted. So in ultrasonography, what you can see is there is increase in nuchal translucency. Okay, increase in nuchal translucency, very important MCQ. So the nuchal translucency, in the nuchal area, in the neck area, there will be a very big gap. Nuchal translucency, it will be like black in color. So increase in nuchal translucency is associated with Down syndrome, sir. On ultrasonography, whenever you see the increase in nuchal translucency, that indicates that the baby is suffering with the Down syndrome. Apart from this, apart from ultrasonography, how can you do like some other confirmatory tests? The other confirmatory tests includes, now there is a test called as dual testing. Dual testing. Now in this dual testing, you are going to check for two markers. One is beta HCG and PAP-A. Okay, pregnancy associated plasma protein A. So when you do this dual testing, okay, especially in the first trimester, when you do this testing in the first trimester, now the beta HCG levels in the mother are very much elevated, very highly elevated, and PAP-A levels are going to be decreased. Whenever you do dual testing which shows high levels of beta HCG and low levels of PAP-A in the mother, now it is indicating, it is giving you a signal that the baby is having Down syndrome. The baby might be suffering with the Down syndrome. In second trimester, you can do one more test which is called as a triple test. Triple testing. Now in this triple testing, what are the markers you are going to check for? The markers you will be checking for is again beta HCG. Also you will be checking for alpha fetoprotein and estrogens. Okay, estriol. Estriol is a major estrogen during the pregnancy. Estriol, sir. Now what happens? Sir, beta HCG levels are elevated. alpha fetoprotein and estriol levels are reduced. Now, whenever the alpha fetoprotein levels and estriol levels are reduced with elevated beta HCG levels, then it's indicating that the baby is suffering with Down syndrome. Now, there is one more test which is called as a quadruple test. Quadruple testing. In quadruple testing, what you will check? Beta HCG, the markers, the beta HCG, alpha fetoprotein, same estriol. Along with estriol, you are also checking inhibin levels. Inhibin A levels. Now, beta HCG levels are elevated, inhibin A levels are elevated, but alpha fetoprotein levels and estriol levels are less. So, this like in quadruple testing, this was a question asked in 2019 June exam. So, in quadruple testing, along with beta HCG, alpha fetoprotein and estriol, what else? What is the fourth marker? The fourth marker is inhibin A. So, by doing these three tests, these are the screening tests, dual testing, triple testing as well as quadruple testing. These are the screening tests by which you can say that the baby is suffering with Down syndrome. Okay, now done, sir. After Down syndrome, now the other chromosomal disorder that I am showing you here, guys, can you tell me what is this chromosomal disorder? Where, see, look here, the baby is palate, the palate is having a problem. There is a cleft palate. Okay, you can very clearly see here, there is a cleft palate, sir, and you can see polydactyly, and there is a hole here in the iris. It's looking like a keyhole. Now it's looking like a keyhole. What is this condition called as? This condition which I am showing you, this is called as Patau. Okay, Patau, I used to remember Patau for palate, P for P. Okay, Patau, sir. Patau syndrome. So what is the problem in Patau syndrome? So it is trisomy 13. Okay, trisomy 13, extra 13 chromosome. Okay, chromosome number 13 is extra, which means a cell is having 13 chromosomes, 13. And I have said you, all chromosomal disorders are going to have mental retardation. So even this Patau syndrome, the patients are going to be mentally retarded, mental retardation, trisomy 13. Now, for your exam purpose, what else you should know? Dekho, right? There is cleft lip and cleft palate. Cleft lip and cleft palate is going to be seen. See here, one more P. Okay, that is polydactyly. Okay, polydactyly, extra fingers, polydactyly is going to be seen, sir. Now, these patients are going to have a hole in the iris that is called as keyhole coloboma. Keyhole coloboma, sir. Okay, so you can very clearly see it just looking like a keyhole. We put the key, right? Keyhole, sir. So Patau syndrome, the patients are going to have the mental retardation. Polydactyly is going to be seen. Cleft lip and palate is going to be seen. Keyhole coloboma. And if you want to know, these patients are also going to have patent MCQ, patent ductus arteriosus. And these patients are also going to have the rocker bottom feet. Yeah, most of the students will think rocker bottom feet is seen in the Edwards syndrome. Not only in Edwards syndrome, rocker bottom feet is also seen in Patau syndrome. So these are the important points I want you to know regarding Patau. Okay, if you know this much, enough, sir. Now after this, the next, look here. Guys, can you tell me? Here the patient, here the boy is having, see, dekho, now is a rounded feet. The feet is now rounded, and you can see the skull, it is in the shape of a strawberry. It's in the shape of a strawberry. So what is this syndrome which we are discussing here? This is called as Edwards syndrome. Edwards syndrome. Now in Edwards syndrome, what's the problem? Again trisomy. Trisomy what? Edward 18, trisomy 18. So 3 extra chromosomes. 3 18 chromosomes. Okay, 1 extra 18 chromosome. So these patients are going to have again mental retardation. Okay, now they are going to have, like I said you, it's a strawberry skull. Okay, strawberry shaped skull. Why it is strawberry shaped? Because see, they are going to have small head with a prominent occiput. The occiput is going to be more prominent and the small head, sir. So this strawberry shape, it is because of microcephaly. Microcephaly, small head with a prominent occiput. Okay, microcephaly with prominent occiput is going to be seen. Apart from this, what else are the clinical features which you should know regarding the Edwards syndrome? So these patients are going to have a kidney abnormality, very important MCQ. Sir, this Edwards syndrome is associated with horseshoe kidney, sir. Okay, horseshoe kidney is going to be seen. And if you look at their feet, see, what is this? This is called as the rocker bottom feet, rounded feet, sir. Okay, rocker bottom feet are going to be seen. Okay, rocker bottom feet are going to be seen. And if you look at their hands are going to be like this, clenched hands. Okay, clenched hands. Clenched hands or clenched fingers. So, trisomy 18, important point. What are the important points which you need to know, guys? It's the strawberry skull, microcephaly, prominent occiput with the rocker bottom feet, and clenched hands, horseshoe kidney is going to be seen. So, these are the important points about the Edwards syndrome. What we have completed? We have completed the Down syndrome. See, regarding Down syndrome, just as a recap, Down syndrome, what are the important points? Trisomy 21, mental retardation, okay, the mongoloid faces, upslanting palpebral fissures, okay, oblique upslanting palpebral fissures are going to be seen, okay. Next, mongoloid faces, palmar Simeon's crease, brushfield spots are going to be seen. Now, these Downs patients are going to develop Alzheimer's disease by the age of 40. Downs patients are associated with endocardial cushion defects, Hirschsprung disease, okay. Duodenal atresia is going to be seen. Most common hematological abnormality is abnormal myelopoiesis, okay. Abnormal myelopoiesis is going to be the most common hematological abnormality, but before 3 years it is acute megakaryoblast leukemia, but after 5 years it is ALL. Downs patients, important points completed. Now after that, Patau. What are the important points about the Patau? So Patau, the patients are going to have the cleft lip and palate. Polydactyly is going to be seen. Okay, keyhole coloboma is going to be seen. Okay, rocker bottom feet is going to be seen. Okay, done. Enough. After this, we have discussed about the Edwards syndrome. Edwards syndrome, trisomy 18, mental retardation, strawberry skull, prominent occiput, microcephaly, rocker bottom feet, horseshoe kidneys. Done, sir. Enough. After this, let's discuss about now Turner syndrome. Turner syndrome. Sir, what is the problem with the Turner syndrome? See, the problem, the chromosome, again chromosomal abnormality, sir. But here, it's not the extra chromosome. One chromosome is lost. What is that chromosome that is lost? It's a monosomy X, which means normally a female was supposed to have 46XX, right? 46XX. A female is supposed to have 2 X chromosomes. Now one X chromosome is gone, X0, 45X0 or XO. One chromosome is lost, one X chromosome is lost. So it is monosomy X, sir. Okay, it's monosomy X. Okay, and most of the time the missing X, the chromosome which is lost, that X chromosome which is lost is paternal in origin. So the paternal X chromosome is lost, sir. Okay, see, this Turner syndrome, there is no increased risk with increased maternal age. So with the increase in maternal age, there is a risk of Edward, there is a risk of Downs, there is a risk of Patau, but there is no increased risk of Turner syndrome with increased maternal age. Okay, now this is the image based question which was asked many times, in the exam. See, dekho, now there was supposed to be 2 X chromosomes, but now here X chromosome is gone. There is only 1 X chromosome, dekho. There is only 1 X chromosome. Now, what are the clinical features? If a female is not having 1 X chromosome, what are the clinical features? I used to remember, like, if 2 X's are present, she is a complete female. If she is having only 1 X, she is the half female. Everything is going to be half. She is the half baked female now. Okay, just like a half baked cake. Now she is a half of 50% female. Now what are the problems? So she is going to have a webbing of the neck. Okay, webbed neck. She is going to have low posterior hairline. Now she is going to have a shield shaped chest. Okay, she is not going to have a proper breast. Her chest will look like a shield, sir. Okay, widely spaced nipples with shield shaped chest. The nipples are going to be widely spaced because her chest is like a shield. So the nipples are widely spaced. Next, if you look at her hand, the fourth metacarpal is going to be short. Okay, the fourth metacarpal is going to be sharp, and she is going to have the cubitus valgus. She is going to have hands something like this. Okay, cubitus valgus. I will show you the image. She is going to have the cubitus valgus, sharp, short fourth metacarpal, low neck hairline with a webbing of the neck, widely spaced nipples, and shield-shaped chest. Now, MCQs. What are the serious anomalies that are seen? The most common serious anomalies are the two. Two are there. One is the bicuspid aortic wall. Okay, bicuspid aortic wall and coarctation of aorta. Okay, these are the two serious anomalies that are seen. Bicuspid aortic wall is associated with the Turner's, true, and coarctation of aorta. Renal anomalies. Turner females can develop horseshoe kidney, true. Now, just now we have seen, sir, horseshoe kidney. It is seen with what? Edwards, or it is seen with Patau? Sir, look here. It is seen in Edwards, sir. Edwards syndrome patients will have horseshoe kidney, true. Even Turner female can have horseshoe kidney. Now, these Turner females, they are at increased risk of autoimmune diseases. Okay, all autoimmune diseases are most commonly seen in females. Now, even this Turner female, she is at a risk of developing diabetes and Hashimoto's thyroiditis. Okay, diabetes and Hashimoto's thyroiditis, these are the autoimmune disorders, true. But very, very important point is her IQ is going to be normal. Okay, it's not a there is no mental retardation. Okay, in trisomies, in all the trisomies, there is mental retardation. But here, in Down syndrome, very, very important, her IQ is normal, sir. She is just like a normal regular girl, but she is short, shield chest, widely spaced nipples, webbing of the neck, low posterior hairline are seen. But IQ is normal. If you look at her ovaries, okay, if you look at her ovaries, the ovaries are totally not properly formed. It's a streaky ovaries. The thin sliver of ovarian tissue is present. Thin sliver of ovarian tissues. So there are streaky ovaries. Streaky ovaries. Thin sliver of ovarian tissue is present. So is she going to have the proper menses? No, she is not going to have the proper menses, and she will be infertile. Okay, these females are going to be infertile in majority of the cases. In majority of the cases, these are infertile. Why? Because the ovaries are not properly developed. Okay. So they are going to have the less estrogen levels. Ovaries are not properly there, so they are going to have less estrogen levels. So what happened to FSH and LH? They are elevated. FSH and LH are elevated, but the estrogen levels are less. Less amount of estrogen levels are seen. Okay. Now the same things I have discussed every clinical feature. Now you can very clearly see, sir, this female, this is a normal female which I am showing on the one side. So this female, see, she is having coarctation of aorta, bicuspid aortic wall, cubitus valgus, her hands are going to be something like this, short fourth metacarpal, streaky ovaries, autoimmune diseases like diabetes mellitus, horseshoe kidney, shield-shaped chest, widely spaced nipples, webbing of the neck, and low posterior hairline. Each and every point I have discussed, sir. Every point is discussed. Okay. Now, look here. See this Turner's. One important point. Turner's is the most common cause of what? Turner's is the most common cause of primary amenorrhea. Okay. See, if there is this one female who is suffering with the Turner's, she is not going to get her menses. By the age 12, 13, a normal female will get her menses, but this Turner female, she is not having her ovaries properly, not developed. So do you think is she going to have the normal estrogen? No estrogen. Is she going to have the ovulation? No ovulation, no progesterone, so no menses, sir. So it's the most common cause of primary amenorrhea. Okay. So problem is gonadal dysgenesis. Ovaries are not formed properly. So gonads are not formed properly. There is a dysgenesis, Turner syndrome. Okay. So this Turner syndrome, in Turner syndrome, one more important point I want you to know. This was a question asked. Sir, there is hypergonadotropic. Hypergonadotropic means the gonadotropic hormones. There is no problem in the brain. There is no problem in the brain. There is no problem in the hypothalamus, or there is no problem in the anterior pituitary. So FSH levels are elevated. LH levels are elevated. There is high FSH, high LH, sir. Why? Because ovaries are not developed. When the ovaries are not developed, there is no estrogens. Estrogens are not there. Progesterone is not there. When estrogen is not there, there is no negative feedback. When progesterone is not there, there is no negative feedback. As there is no negative feedback, the FSH levels are elevated, LH levels are high, but estrogen levels and progesterone levels are low. So that's why hypergonadotropic, gonadotropic hormones are more, FSH is more, LH is more, but hypogonadism, gonads are not there, ovaries are not there, hypogonadism. So hypergonadotropic hypogonadism, example is a Turner's. Okay, so all important points about the Turner's are completed, sir. The last chromosomal disorder which I want to discuss here is Klinefelter. What is the problem with the Klinefelter? Very simple thing. So it's going to occur in the males. Why? What is the problem? So 47XXY, the most common, the genotype abnormality is 47XXY, which means one extra X chromosome. Normally it should be 46XY, right? A male is supposed to have, for example, 46X and Y, one X chromosome, one Y chromosome. If there is an extra X, now it becomes 47 chromosomes are there. What is that extra chromosome? One extra X chromosome is there. For example, this is 48XXXY. This is also Klinefelter. This is also Klinefelter, no doubt. So extra X chromosome is simple Klinefelter. Okay. Most common genotype is 47XXY. Now what happens? Normally XY is male, XX is female. Now if a male is having one extra X, X is more female, right? If a male is having one extra X, female-like characters will develop. Female-like characters. What are those female-like characters? Now gynecomastia, dekho, now he is having breast tissue development. Gynecomastia. True. Now if you look at his testes, the testicular atrophy will occur. There is testicular atrophy. Okay, there will be micropenis, testicular atrophy, and even in this testis, there are no sperms. Azoospermia, MCQ, there are no sperms. But if you look at their height, they are going to be tall statures. So that their height is going to be tall. They are tall stature with gynecomastia, azoospermia, and if you talk with them, the voice is going to be more girlish. Okay, that's high pitch voice. High pitch voice. Okay, they are going to have the high pitch voice. And are they going to be fertile now? No, they are not going to be fertile because there are no sperms at all. Okay, they are going to suffer with infertility, and yeah, in some patients there will be mental retardation. Some patients with Klinefelters will be normal also. There are variations are there. Okay, but anyway, Klinefelters is a male who is almost having the feminine characters like high pitch voice, gynecomastia. Okay, gynecomastia. And if you look for the sperms, there are no sperms. As there are no sperms, there is infertility. Okay, there is infertility, sir. So now these patients, they are at a risk of breast cancer. Also, this is also important point which I want you to know. They are at risk of breast cancer. So the Klinefelters. So Klinefelter is an extra X chromosome. So with this, all the chromosomal disorders also I have completed. The Turner's, Edwards, Patau, Turner syndrome, as well as the Klinefelter syndrome. So with this, all the important points, whatever you need to know for your exams are completed. Okay guys, the topic is completed. Hope the lecture is helpful. One more. Yes, hope the lecture is helpful. I hope I have completed everything. Okay, all the important points. If you know this much, that will be more than enough for your exams. Okay, so in the next class, let's start the new topic. We have completed the cell injury, we have completed the inflammation, also we have seen important points from the genetics, important topics from the genetics. We are done, sir. We are done with the genetics. Now in the next class, let's begin with the new topic, new systems. We'll start with the, if possible, we'll start with the systemic pathology. The more interesting, more like we can do more integrations. Okay, cardiovascular pathology, vascular pathology, okay, lung pathology, we'll do. Okay, okay guys, enough for today. See you in the next class. Thank you. Good night.